Good evening. Can everybody hear me now? Okay. So this is the class on a quiz on angiography and echocardiography. Now I'll be having more of related to angiography, but I'll just start with a quick echocardiography picture. Now I'm going to deal with very basic things, and I expect you to answer questions quickly. You have to be fast so that we can see as many pictures as possible. Now, can anybody tell me what this signal is and what it is about? Yes, I'm waiting for the answer. Can somebody talk or type the answer? Can you hear me? Yeah, well, that's, don't say the gradient across the mitral valve. How do you describe it? Describe it. That's the way to answer. I'm asking you, what is this picture? Anybody else? Now, that's not the way to describe this picture. You don't say enough gradient. What is this picture? You have to tell me what this picture is first. I'm going to wait for another 5 seconds. Okay, pulse Doppler across the mitral valve. Now, see, you must learn to be very scientific in your terminologies, because it creates a much better impression if you use scientific terms to describe nerves. Now, this is a spectral recording. This type of recording of Doppler is called spectral, and the signal that has been recorded is called the spectral envelope. Okay, this is a spectral recording of a continuous wave Doppler. It is not pulse wave Doppler. Somebody said pulse wave Doppler. It is continuous wave Doppler because the velocities are fairly high, close to 3 meters per 2.5 meters per second, and therefore it's a continuous wave Doppler spectral recording from the apical window across the mitral valve. Now that's the way to describe it. Okay. Now, once you have described what this figure shows, you go on to the findings. And what are the findings? What are the findings? Can anybody type now? The figure is a spectral recording of a continuous wave Doppler flow across the mitral valve from the apical window. Now, what does it show? What does the Doppler recording show? You have to be quick, otherwise we won't be able to finish all the spotters. Okay, since I'm not getting any answer, I'm going to go ahead with the description. Now, it shows that the diastolic velocities across the mitral valve is increased. Now, it is increased because normal velocities across the mitral valve are in the range of less than 1 to 1.2 meters per second. Here the peak velocity is going up to 2.5 meters per second. So the velocity is increased. It is not only increased, it is very intense. You can see that the whole envelope is filled up by the echo noise, and that is due to commonly the term uses turbulence, but what is happening is that the RPCs are moving at a high velocity, and the velocities RBCs are moving in different directions within the stream. They are not moving in one parallel uniform direction. Therefore, this reflects an increased velocity of flow across the mitral valve. Increased velocity and increased dispersion of velocity, like some RBC is traveling in the low velocity, some RBC is traveling in the high velocity, indicates that there must be a pressure gradient across the valve. When there is a pressure gradient, it means there is obstruction. Now, the other important finding you have to talk about is the rate at which the velocity is coming down. This slope, what is the slope called? Somebody type quickly. No, the slope is not called a pressure half time. The slope is called the EF slope. The E point here, and yes, in N mode it's called EF slope, and in Doppler it's called deceleration time. Yes, this slope normally is very sharp and going downwards. Here, the deceleration time is increased, and therefore it becomes more horizontal. Now, this slower rate of filling across the mitral valve lasts for a much longer time, and it continues into the late part of diastole almost until the next QRS complex. Now, another important thing you notice is that there is no separate A wave at the end of diastole. Isn't it right? Why is that? Why don't you see an A wave at the end of diastole? Anybody? Yes. This is atrial fibrillation. You can see that there is no A wave at the end of this A filling at the end of diastole. You can see that the diastole are different in length. This one is a short diastole. This one is a long diastole. Therefore, they are of varying cycle length. And the accompanying ECG confirms that there are no regular P waves. So therefore, this is a recording of a mitral valve gradient, mitral valve velocity spectrum, spectral velocity in the mitral valve in a case of mitral stenosis with atrial fibrillation. It shows increased gradient in early diastole. It shows that the gradient persists in the mid diastole. It also shows the gradient persists in the late diastole. Right? Therefore, it must be a significant degree of mitral stenosis. How do you quantify mitral stenosis from this recording? Somebody said pressure half time earlier. Now, pressure half time, can somebody tell me what is pressure half time and how it is measured? No? Now, pressure half time is the time taken for the pressure gradient to drop to half its initial value. If you can see that the velocity here is maximum and it drops during diastole. So the time taken for this pressure gradient to drop from this value to half of its initial value is called the pressure half time. Now, please note that it refers to the pressure gradient and not to the peak velocity. It's not the peak velocity and the time taken for it to fall to half of the velocity. It is the pressure gradient at the peak and the time taken to fall to half of its velocity. Normally, you can find out half the velocity because the equation is 4 into velocity squared is pressure gradient. It's equal to when the velocity falls to about 70% of peak velocity, that would be the time when the pressure gradient has dropped to half. Therefore, it would be somewhere here. It would be somewhere here. So 0.7 of the maximum velocity, to plot a point here and draw a vertical line, and the time interval from the initial peak velocity to the 70% velocity. That is the time interval for pressure half time. More the pressure half time, the more severe the mitral stenosis. That's right. Okay. So the mitral gradient in mitral stenosis, it shows early diastolic and late diastolic gradients. It shows that the pressure half time would be increased. All of this indicates that there is significant mitral stenosis. Another way of quantifying mitral stenosis would be to measure the mean gradient. How do you measure the mean gradient? You measure the gradient, average it over the entire diastole. And to do that, what you do is you can do either measure velocity, the gradient at multiple points in diastole like this, along diastole like this, and take the average. Or a much simpler one is to do a planimetry and trace the area under the Doppler signal, and when you trace the area and multiply it by the scale, you get the mean gradient. So there are two ways of quantifying mitral stenosis on this tracing. One is the pressure half time, and other one is a mean diastolic gradient. Now, gradient is only one criteria for calculation of severity. In general, higher the gradient, more severe the mitral stenosis in general. Please remember that a gradient is related to cardiac output. If you have mild mitral stenosis and if you have a high cardiac output, you will have a high gradient. If you have severe mitral stenosis and if you have a very low cardiac output, you will have a very low gradient. Therefore, a gradient should always be interpreted along with the cardiac output. So, for a normal cardiac output, higher the gradient, greater will be the severity of stenosis. Okay. Now, please note the difference between this abnormal tracing, where the velocity is increased, it is very turbulent, and there is a lot of dispersion that the whole area inside the curve is filled up with opaque echo, indicating there is a lot of variation in the velocities of the RBC. Now compare this to the tracing in a normal mitral valve. Compare this to this. Now, can somebody describe this tracing for me? What does it show? Now, this is also a spectral recording of the mitral valve Doppler across the mitral valve from the apical window. Now, this is the normal pattern. It shows velocities of less than 1.5 meters per second. It shows a sharp decrease in velocity in the mid diastole, and then again filling of the mitral valve and left ventricle during late diastole because the atrium contracts. Now, the interesting finding is you find that the border is very clear and opaque, whereas the center is relatively clear. And this is what is called a laminar flow, or the normal pattern of flow. It is a clear thing, interior and that opaque border. Now, this laminar flow occurs when all the RBCs are moving at a uniform velocity, and all the velocities are concentrated at this band, within this white band. Whereas in very turbulent flow, what happens is some velocities are moving at peak velocity, some are moving at the lower velocity. They are moving in different directions within the turbulent stream, and therefore this whole area gets filled up with echo, and that produces what is called a turbulent flow. Whereas this is a laminar flow. So laminar flow is characterized by normal velocities, clear borders with clear, very sharp borders with clear centers, and normal time patterns. Okay, so this is a normal pattern. Now, when you measure EF flow, sometimes you may not have a clean slope. You may have a tracing. Ideal tracing would show a slope like this, okay, from beginning to end of that. Occasionally, you have a very sharp peak in the beginning and then a gradual slope. So, where do you measure the rate of decline? You could measure here when it would give a very high rate of decrease, and therefore the pressure half time would be very, very small. Whereas you could measure in the later part of the tracing here, which would give a longer pressure half time and therefore give a smaller mitral valve area. Now, the correct method of measurement is not to measure the initial part. The significance of mitral stenosis comes in mainly in mid and late diastole. Because in early diastole, even the normal mitral valve may have a small gradient. Therefore, the best area to measure the falling gradient and half time is the slope in the middle straight part of the tracing. So this dotted line indicates the correct area where to measure the pressure half time rather than the initial part where it is sharply falling. This is not the right place. The right place is from here to here, where it is straight. Okay? Are you following? Type S if you are following. Okay. Right. Now moving from echo to this thing. Now I made a list of. I'm going very basic. Let's see how many of you have worked. Many of you would have worked in the cath lab. You have used numerous contrast agents. I made a list of contrast agents here. Now, can somebody tell me which agents would you like to use amongst them for a sick baby or a child with congenital heart disease? You have a big choice in the market. You are the person in charge of the cath lab, and you're being asked to buy a contrast agent. Yeah, come on, you have to be fast. Yeah. Iohexol, yeah. Bharati said iohexol, very good. And I got one more answer, Vikas Gupta, iohexol. Yeah, now tell me why. Why did you choose iohexol? You are right, but tell me why. Non-ionic, very good, Bharati. Yes, I'm glad. You're right. Now, contrast agents are agents which are what you call attenuating agents. Attenuating agents means they absorb X-rays and do not allow X-rays to pass through the heart, and therefore they cast shadows. They are very useful in delineating vessels and chambers and defects and other things. Now, all of them contain iodine, and iodine cannot be injected straight. Iodine has to be combined with some other binding agent to make it injectable. Therefore, they have a medium for injection, and out of these, they have different properties. I made a list in which the blue colors are the ones which are often used in sick patients with either coronary artery disease or LV dysfunction. The first three ones are not to be used because they are what is called the high ionic content contrast agents. The latter one are called non-ionic agents. Bharati or Vikas, whoever said that, can you tell me what's the difference between ionic and non-ionic? All the blue ones are called non-ionic here, and they can be used in children. Iohexol is a very popular one, yes. What's the difference between non-ionic and ionic? Anybody? No? Okay, and I have received no answers, so let me go on to that. Yeah, I made a list of commonly used iodine agents. Now, iodine, all these contrasts have three properties. Of course, there are many properties. I've just listed the three important ones. One is the name is given ionic. I'll come to that. There are two broad types of compounds called monomers, and there are other compounds which are called dimers, and they're called ionic and non-ionic. They also decide the amount of content in terms of milligrams per 100 per ml, and finally the osmolarity in relation to the plasma. Anybody tell me what is the normal osmolarity of human plasma? Yes, 280 to 290. Right, Vinod, you are right. 280 to 290. You can see that all contrast agents are hyperosmolar. There is no agents which are truly isoosmolar or hypoosmolar. All of them are hypoosmolar. Now, the toxic effects of a contrast agent are directly related to osmolality. Osmolality is the density in relation to the plasma. These are all denser than plasma, and that is the main, and therefore they are also very viscous, and that's the main cause of toxicity, including toxicity on the kidney, brain, and other systems. Now, all are hypo. Now the important thing is, you can see all these contrasts have almost a similar content of iodine. The content of iodine is similar, but what changes is the amount of iodine in relation to the osmolarity. You should have a high iodine to osmolarity ratio. For example, here it is almost 1:5, whereas here it is only 1:2. Our iohexol is about 1:2.5. Therefore, whichever contrast has a high iodine content and in relation to osmolarity, that is, for example, this one has 1:almost 7. Now, these are 5 to 7, these would be very toxic agents for children. Whereas you can see here, this one is only 1 to 2.5, 1 to about 2.5 or 3. This one is even better, 1 to 2 or less than 2. Now, these are a very high iodine content as compared to the osmolarity, and therefore these are called low osmolar. Now, they are called low osmolar. It's only relatively low osmolar because they are still hyperosmolar. They are still 2 to 3 times normal osmolality, but they are called low osmolar because they have a high iodine content in relation to osmolarity. Okay, that's one factor. The other factor is whether they are ionic or non-ionic. What is ionic? Ionics are contrast media which, when injected into the blood, when they come in contact with serum, blood or plasma, diluted into more volume, the chemical breaks up into anions and cations. So this is not good. So when they break up into anions and cations, again the viscosity increases. Once the viscosity increases, the contrast toxic effect increases. Whereas the non-ionic ones remain as unbroken ions. They don't break up into cations and anions. So there are the two terms. One is the relative osmolarity, and two is whether they break up into cations and anions in solution. So these are two properties, and they are more or less related. Most of the ionic ones also happen to be high osmolar. Okay, most of the ionic contrasts happen to be high osmolar. That means they have a relatively lower iodine content for a given degree of osmolarity. They not only produce a high incidence of a high amount of anions and cations, they also produce a high osmolarity for a given amount of iodine. So we want as much iodine as possible with a lower osmolarity and which doesn't break up into cation and anion. We have no perfect agents. They are all relative. Therefore, we choose the agents which have highest iodine content for a given osmolarity and at the same time are non-ionic. Now, which are the ones among these? We get ioformidol, we got iohexol here. They are non-ionic. At the same time, they have a relatively low osmolality for a given amount of iodine. So these are considered the best ones for children. As well as they are also good for the sick coronary artery disease and LV dysfunctions and all that. If the patient is a normal adult, you don't mind using anyone. But then for any sick patient, and that's all good for children, we prefer to use low osmolar non-ionic contrast. Iohexol is one of the most popular ones from the brand name being Omnipig. Even in iohexol, you have two varieties. You have Omnipig 350 and you have Omnipig 300, depending on the iodine content here. Obviously, you prefer Omnipig 350 for cardiac angiography, so you want better delineation with lesser volume of contrast, right? Okay. Now, these are the ideal qualities of a contrast agent: low osmolality, low viscosity, high water solubility, biological inertness, safety, stability, and cost effectiveness. Unfortunately, we have no contrast media which fulfills all the criteria. Iohexol fulfills the first three of them, but it is quite expensive. Whereas the other ones have a higher osmolarity, but they are often cheaper. So somewhere you have to be a trade-off. Okay. Now I'm showing you two X-rays, and the X-rays are labeled already. But tell me the differences between these two X-rays. Somebody can tell me what is the difference between a chest X-ray in the PA view and a chest X-ray in the AP view. How to identify it? Because when you see an X-ray chest, very often the labeling is not very clear. It's an anteroposterior view or anteroposterior view are typically taken at the bedside when the patient is in ICU or post-operative state. Whereas PA chest is the one you prefer whenever you can do it in the radiology department. What is the difference in the X-rays between the two? Can somebody describe it for me? No, apparent cardiomegaly is there, I agree, but first you must recognize it AP, then only you can say apparent cardiomegaly. If I see only the X-ray on the right side, how will I know it's AP chest? Only after I know it is AP chest, then I know it is apparent cardiomegaly. I may mistake it for real cardiomegaly. How do you identify? In PA view, clavicle is more slanting than in AP view. Yes, you're right. Can you tell me why? You're right. The clavicles are more slanting in PA view, but why? Hugging the plate. Very good, Vinod. Yes. See, in a PA view, when they take in the department, the technician asks the patient to raise the arm and bring it forward around the X-ray plate like this, hugging the plate. Therefore, not only the arm is raised, the clavicle is raised, and the scapula is moved out of the vein. That's a major difference between the two. You see, the clavicle is more oblique, and the scapula is moved completely out of the chest. Whereas here, you can see that the scapula comes very much inside the chest. Can you see the scapula here? And the clavicles are perfectly horizontal. Therefore, you must be wary of AP X-rays because, as somebody said, AP X-rays always causes apparent cardiac. Can you see that the X-ray shows the heart size appears to be more here than in this view? Why is it that? Because here the X-ray chest is closer to the heart is closer to the X-ray beam. When it is closer to the X-ray beam away from the X-ray plate, there is a tendency for X-rays to diverge as it comes out of the heart and goes towards the posterior chest wall and hits the X-ray plate, and that is what is called the apparent magnification. It's also called the pincushion magnification. The X-rays are diverging. They enter from the heart and they exit from the heart and exit from the chest at the posterior wall. It becomes wider and it gives an apparent cardiomegaly. The PA view does not cause this apparent cardiomegaly. Therefore, when you are measuring CTR, cardiothoracic ratio, in a portable X-ray at the bedside, please be very careful about describing cardiomegaly. Okay? Now, if you have a whole X-ray like this, it's very easy to say it is AP view. When you look at an angiogram, you rarely get the whole chest. You only get a small portion of the chest. This is the typical angiogram. This is the typical view. When you get an angiogram, it looks more like this because they reduce the field. Now, can anybody tell me why they reduce the field? Why do they reduce the field when you do an angiogram? No. They don't reduce the field of magnetism. Okay, radiation, because it's right. One is radiation is less. Radiation exposure to the patient and radiation exposure to the people in the cath lab by scatter is less when you reduce the field. And how do you do it? It is called collimation. Collimation is the term used when you reduce the circle round. This is a circular frame. Collimation. In some of them you may have a square frame. Some of them you have an octagonal frame. Whatever it is, you reduce the area exposure to the area of interest. If you want to study this area of the heart, you expose the excision. Now, when you reduce the area, the amount of X-rays you need is reduced. Therefore, radiation is reduced. Secondly, you might get much better exposure. So, when you expose the X-ray over a large area, there would be some very dense areas. There would be some translucent areas, and the camera gets confused, and the exposure may not be all right. It may come out as very white or very dark. Whereas the smaller the area you give to the automatic camera, it is able to find out the appropriate exposure and give appropriate contrast. Therefore, it's always collimated to the small area. Now, when you get a small collimated area, how do you identify AP view? Now, angiogram is always an AP view, never a PA view. If you notice in the cath lab, the X-rays always come from behind the patient, and the image intensifier is on top, right? But unlike, no, I'm sorry, it's always an AP view in X-ray, and the image intensifier is generally at the bottom in most X-rays. It may vary from case to case. But whatever it is, whether it's AP or PA view in the angiogram, you get only a small area to identify it, and therefore most operators will just describe it as a frontal view. Now, in frontal view, how do you know it is frontal view and not an oblique view? Can anybody tell me in this? How do you know this is not an oblique view? Because you're not seeing the spine, you're not seeing the ribs in complete. How do you know it's a frontal view? The best thing is to look at the vertebral bodies. The vertebral bodies have two pedicles. This is pedicle on either side. Those two pedicles are two pillar-like things. It goes from the vertebra backwards to the spinal to fuse with the spine. Now the canal is in between. Okay. Now the two pedicles are seen end on. One oval shadow here and one oval. If you see the two pedicles completely end on at an equidistance from each other, you know that the spine is straight looking at you, and therefore this must be a straight frontal projection. Whenever you do an oblique, these two pedicles will not be seen end on. Right? So therefore, this is the typical view of an frontal view of the frontal angiogram. Okay, and most of them would be anteroposterior view. Now, what view is this? On first. Okay, lateral view. Now, how do you describe a lateral view X-ray? It's easy to find out lateral because you are used to it. But then, how do you identify lateral? You find the lateral because you find that the two sets of ribs, one on the right side and the left side, are perfectly superimposed on each other. You can see that the right thorax and the left thorax are perfectly superimposed on each other. You don't see the two sets of ribs separately. You see that the sternum perfectly seen, the side view of the sternum perfectly seen, and then a transfer section from the side. And you can see that the vertebral bodies all form beautiful rectangles stacked on top of each other. Now this tells you that the chest X-ray is a lateral view. Now it's easy when you have the whole thorax in that like thing. How do you identify lateral view in an angiogram when you collimate it to a very small area? So this is also a lateral view. How do you identify this? And here you don't see the whole of the chest, but here whenever you do a lateral view angiogram of the heart, you will always see the sternum, and you can see that both the plates of the sternum, the anterior plate and the posterior plate of the sternum, are perfectly aligned. That means you are seeing it as a one single line. If you have an oblique view, you will have one at the right edge and one more line of the left edge. You won't see two parallel lines here. Okay, and you can see that the vertebral bodies are also perfectly stacked on top of each other with perfect rectangular boxes. So that tells you it's a lateral view. Now, lateral view is a great view for looking at anterior structures. Now, what are the anterior structures? You can, for right ventricular angiogram, as you see here, right ventricular outflow tract, and for profiling the pulmonary valve here. You see the pulmonary valve here? That's the pulmonary valve here. And the main pulmonary artery, or the aorta is coming from the RV. This is the aorta actually, not the pulmonary artery, sorry. So this is aorta. This is the case tail coming from the femoral artery going into the RV. And So either pulmonary artery or aorta, whichever is anterior, to outline the anterior chamber and the anterior great artery. A lateral view is a good view. Now compare this with the next view. What view is this? You have to be fast, please. We are running out of time. Right anterior oblique view. Now, can you describe it further? How do you? No, don't say oblique. You have to say right anterior oblique view. How do you know it's right anterior oblique? Because now, when you shift the patient to right anterior oblique, the right-sided ribs tend to move towards the right front and towards the right side of the extracellular, whereas the left-sided ribs tend to move posteriorly. But the spine is closer to the left-sided ribs. Therefore, you see that the spine is on the closer to the left side of the screen, and the distance from the ribs to the spine here is much shorter than the distance from the vertebra to the ribs on the right side. Okay. So this is the right anterior oblique view. Again, once you have a large chest X-ray, it's very easy to identify right anterior view. But when you're looking at an angiogram, you often collimate it into a very small area. Now, how to identify right anterior oblique view in this? I borrowed this figure from Grossman's book. How to identify right anterior oblique? Here you depend on the position of the spine and the shape of the heart. If the spine is close to the left border of your image, and your heart forms an ellipsoid and the apex is pointing down and to the left of the image, you have to remember the shape. Because here you don't have the whole chest. You have to remember the shape of the heart. It forms an ellipsoid and it's pointing towards the left lower corner of the image. This is an anterior oblique view. In contrast, this is an right anterior oblique view. And this is one of the best views to study the mitral valve, left ventricle, and right atrium. So if you see that, and now this is an example of a mitral regurgitation. LV angio, where it's showing mitral regurgitation filling the LA. It separates the LA from the LV. You can see the mitral valve is it also separates from ascending aorta from the left atrium. And you can see the shape of the LV profile very well. The apex pointing down and left, sitting on the diaphragm. Therefore, it will be very good view for seeing ascending aorta, left ventricle, mitral valve, and the LA. You also see the descending aorta behind the heart, the posterior medial. So, right anterior oblique view, spine towards the right side of the image, and an ellipsoid image with apex pointing down and leftward is right anterior oblique view. Compared to that, what view is this? Now this is the opposite of right anterior oblique view. Here you see that the spine has come towards the right side of the image, and most of the heart is in front of the spine towards the left of the image. And the shape is different, no longer ellipsoid. It looks more spherical. The apex is more round. This is quite different from the previous image. The previous image, the spine is on the left of the image, and the ellipsoid, the apex pointing down and left. Whereas now, the spine is on the right of the image, and it forms a spherical image with a rounded apex pointing down and rightwards. This is an example of left anterior oblique view. Left anterior oblique view is a great view for visualizing the left ventricle, especially the septum of the left ventricle and the left ventricular output side. Okay? So this is left anterior oblique view. Is that clear? How to identify frontal view, how to identify lateral view in X-ray, and how to identify the same thing in angiogram. I also talked about how to identify right anterior oblique view and left anterior oblique view in the X-ray chest. And then I told you how to identify right anterior oblique view and left anterior oblique view in the angiogram. Right? Are you clear on that? I know this is very basic stuff, but I think you should be able to answer this question and convince yourself and the examiner as to what is anterior oblique view when you see an angiogram. Okay? Any questions on that? Okay? If there are no questions on that, I go to this angiogram. Now, this angiogram, this is an angiogram which you have to interpret for me. And I told you how to interpret an angiogram. I'll run this angio. Again, I borrowed this angio from somebody else. Okay. Can somebody interpret this angio for me? It will keep running in loop. And I'll stop it for you if you want. Anybody would like to comment on that? I'll stop it for you. One frame I'll stop it in diastole, one frame I'll stop it in systole for you. Okay? I'm sorry, that went past. Okay, that's the systolic frame. Okay, and now I'm going to the diastolic frame. Right, that's the diastolic frame. Anybody want to talk about it? RAO cranial angulation. Yes, very good. Now, you have to tell the answer and complete. This is a pigtail catheter passed retrogradely through the femoral artery and the aorta into the left ventricle. So therefore, it's a retrograde left ventriculogram being done in right anterior oblique view with cranial angulation. Very good. That's a good beginning. Now what? Now interpret it. Do you want me to run the angio or are you happy with the still frame? Now you have to interpret it. You want me to show the live angio again? I'll run it for you again. There's a lot of information in an angiogram. You have to interpret the whole angio. LVH is dynamic. Dynamic what? Subvalvular obstruction. No. Okay, I'll show you the diastolic frame and systolic frame once more. Okay, this is the diastolic frame. Right? Everybody have a good look at the diastolic frame. Right? And now I'm going to show you the systolic frame. Okay, that's the systolic frame. Right? And now I'm going to run it. Okay. Now I'm going to, okay, you've not been able to make up the, now I'll show you another angiogram. See whether you can see any difference between this angio and the next angio. Okay. Look at this angio and see whether you see any difference. Here I will show you the diastolic frame and the systolic frame. Okay, this is a diastolic frame, right? And a systolic frame. This is a systolic frame. Will be regarding the specification of now. Okay, I'll go back to the previous angio. Okay, this is the previous angio. We'll go back one more angio. When you look at this angio also I showed you earlier. Okay, this is the diastolic frame in here. Now can you see the diastole, the LV outflow is wide open, and in fact the posterior border of the mitral valve is seen here. It's continuous, the outline of the mitral valve ends at the aorta here, okay? And therefore the mitral valve, this portion of the septum is called the atrioventricular septum. The septum between the left ventricle and the right. Now, when you go to the next angio, this angio, just watch here. Okay, this is the diastolic frame. Now, can you see that the LV outflow is narrow and elongated, and you don't see the atrioventricular septum here. The mitral valve posterior border is here, but the anterior border is placed quite anteriorly and superiorly here. Okay, and what is the shape called? Shape of the LV. What is the shape of the LV called? Gooseneck deformity. Now, come on, yes, Marhan, at last you got it. So this is the classical gooseneck deformity, and what does it indicate? What does it indicate? AV canal defect. So this is the classical gooseneck deformity of AV septal defect. Now it's not common AV septal defect. It can be partial AV septal defect also. Both partial and common AV septal defect can produce a gooseneck deformity. So the gooseneck deformity is produced by a disparity between the posterior length of the posterior interventricular septum and the anterior interventricular septum. See that the anterior or superior part of the ventricular septum has a much longer length as compared to the inferior part of the ventricular septum. You know, the ventricular septum is scooped out in the AV canal defect to produce a large endocardial cushion defect. This portion is scooped out, and that produces a gooseneck deformity. There is a disparity between the length of the ventricular septum in the inflow portion and the outflow portion. Okay, so it produces a gooseneck deformity, and this is the back of the goose, and this is the neck of the goose. Okay. Now the question is whether this is a complete AV canal defect or is it a partial AV canal defect? Can anybody tell me that? Come on, you have to be quick. We are going to run out of time. What is the difference in partial AV canal and complete AV canal? The difference is in partial AV canal there is no VSD. In complete AV canal there is a VSD. Now tell me, is there a VSD or not? In a frontal view you will not actually see the VSD, but there is indirect evidence of VSD. You can see the pulmonary artery filling here in front of the aorta. Can you see the contrast going into the pulmonary artery here? Yes or no? Can you see the contrast going in the pulmonary artery here? So how can the dye enter from the LV to pulmonary artery unless there is a VSD? Therefore, this is a complete AV canal defect. Now, what are the other components of AV canal defect? Quick, you have to be quick. The other component of AV canal defect is mitral regurgitation. Is there a mitral regurgitation in this case? See, if you look at the earlier part of the frame, the LA is not filling. In the earlier part of the angio, there is a systolic frame, there is no filling of the atrium. It's only when the pulmonary artery fills and late in the cardiac angiogram that you get the atrial filling from recirculation from the pulmonary vein. Therefore, there is no mitral regurgitation and the atrium is filling only when the pulmonary artery fills and recirculation comes. Therefore, this is an example of a complete AV canal defect because there is pulmonary artery filling through the VSD, gooseneck deformity, but there is no significant AV valve incompetence. Right? Agree? So that's a gooseneck deformity. Now compare that to a normal LVA, you don't get a gooseneck. In a diastolic frame, you don't get a gooseneck. The atrioventricular septum is present and the LV outflow is wide open here. The posterior length of the interventricular septum is as long as the anterior length of the interventricular. This length and this length are equal. In AV canal defect, it's scooped out like this. Okay? Okay. Now can somebody describe this angio? What do you expect? They barely got another 10 minutes to go. What view and I told you how to identify views short while ago. So it identifies views, what angio, and okay, now I'm going to stop it in one second. Okay, I'll stop it. Sorry, say that again. I missed that. LV angiogram is okay. Pigtail catheter retrograde through the aorta into the left ventricle. This angiogram has been done in what view? Elevocranial. Very good. Yes. Because the spine is closer to the left border and the heart is forming a more globoid shadow. Agreed. This is a elevocranial view. Now, how do you notice cranial view? Somebody said cranial. I agree with that. But tell me how you identify cranial. Why can't you say it is caudal? Yes, because the heart is overlapping on the diaphragm. When you go cranial, the X-ray beam travels through the heart as well as the diaphragm. Therefore, the heart is overlapping on the diaphragm. When you go caudal, the cardiac cellus will be lifted up above the diaphragm. So this is the cranial view. Okay, now describe the angiogram. What does it show? This frame shows what I want to show you. Elongated LVOT, yes. What else? Spade type of effect. No, this is not a spade effect. Not at all. You see, this is a gooseneck deformity in the other LAO view. This is a LAO angio in a AV canal defect. See, can you see that the LV outflow is elongated and the inferior border of the septum is scooped out here, and therefore the inferior length of the ventricular septum is much shorter than the anterior length of the ventricular septum. So the length from here to here is much longer than from the length here, crux to here. Crux to apex is much shorter than the aortic valve to the apex. So the disparity between the inferior or the posterior length of the septum and anterior length due to scooping out of the mitral of the septum. Now can you see that the mitral valve is abnormally oriented? Normally your mitral valve orifice is profiled in the left superior corner of the LV. Here the mitral valve is abutting the septum here like this. Yes, this is the gooseneck deformity in the LAO view. Can you see the back of the goose? This is the back of the goose and this is the neck of the goose. Now, as a scientific person, the word gooseneck deformity is not a good thing to talk about, because the gooseneck is only a pattern. Now, it's always better to describe what the abnormality is. You must say that the LVOT is elongated because the septum appears to be scooped out, and there is a gross disparity between the length of the posterior part of the ventricular septum and the anterior part of the ventricular septum, indicating a AV canal type of defect. This appearance happens to be called a gooseneck. Is that clear? Yes or no? I don't see any responses. So, yes, it is a gooseneck pattern, but in the exam I will be much happier if you don't call it gooseneck. Say gooseneck at the end. You must say that the LV outflow tract is elongated. The septum appears to be scooped out. There is a marked disparity between the length of the posterior ventricular septum as compared to the anterior interventricular septum. This appearance is called a gooseneck. Okay? So now I'll run this angio and tell me if it's a complete AV canal defect or an incomplete AV canal defect. Complete or incomplete? Come on, I'm not getting any answer. Partial, because there's no RB filling and there's no PA filling. Now this is a different patient from the previous patient. So this is also a gooseneck, but this is not, this is a different angio. So this is a partial AV canal defect without a ventricular septal defect. And is there any mitral regurgitation in that? No, because the LA is not filling at all. Therefore, this is a partial AV canal defect with no mitral regurgitation. Okay, so I've shown you two examples of gooseneck, one in a complete AV canal defect, another in a partial AV canal defect, one in RAO view or AP view, one in LAO view. But the features are the same. Okay. Now another important feature is when you do an angiogram, you got to describe all the features. Now, it's not enough if you just describe the most important feature, because the angiogram is a difficult invasive procedure. You try to get as much information as possible from the angiogram, and therefore, when you run here, there is a gooseneck deformity. There is no mitral regurgitation. There happens to be a VSD, pulmonary artery filling, and all that. But then that's not enough. The pulmonary artery appears to be dilated. Even the pulmonary artery is twice the size of the aorta. Therefore, the shunt must be very large, and therefore they must be having hyperkinetic pulmonary hypertension. There is no mitral regurgitation. In the LEMO phase, you find that the atria are filling. That means the pulmonary veins are coming back to the atrium. There is no AV canal defect often accompanies conditions like isomerism, where the pulmonary veins can be going elsewhere. Here, the pulmonary veins are all coming back to the atrium. Now, when it comes back to the atrium, you see only one atrial mass is filling. You don't see a LA filling separately and RA filling, and then RA filling through the ASC. Therefore, very commonly they have a large primum ASC, and you cannot differentiate LA and RA. So this angiogram you must actually describe as evidence of complete AV canal defect, indicating a large intra-atrial communication and a large interventricular communication, no mitral regurgitation. There happens to be a large pulmonary blood flow because very rapid circulation in a dilated pulmonary artery, and most likely this patient is likely to have hyperkinetic pulmonary arterial hypertension. The pulmonary venous connection appears to be normal, and there is a large intra-atrial communication. Okay. In addition, you can also talk about LV function, eyeballing of the LV size. Now, unfortunately, you don't see the aorta very well here. You can always talk of the aorta, whether it's normal, whether it's a left arch and a right arch. You can also talk about any presence of stenosis of the LV outflow tract. Okay, right. Let me go ahead. And this is my final slide. Can anybody tell me what view is this? I'll run the angio for you. What view is it? I don't want the findings. I just want view. You know what chamber it is being injected, no? It's a pigtail catheter retrogradely passed into the aortic root and we are injecting. Yes, somebody said something. LAO caudal view, very good. Is there any other name for the LAO caudal view? It's also called the laid back view. Laid back view. Now, laid back view is a view. It separates the three aortic sinuses. Whatever view you use, AP, lateral, RAO, LAO, the three sinuses often overlap each other. Therefore, if you want to separate the view and look at the aortic valve end on, this is the best view. You are looking into the aortic valve orifice, and you can see, you will be able to see anterior curve and posterior curve, a right-sided, left-sided, and anterior, or the relationship as well as anteroposterior relationship. Now, this view is very useful for seeing the proximal coronary artery origin in complex anomalies. I am not going into the details, but how to identify laid back view? Now, you know it's an aortic injection. You're seeing the great vessels in the neck filling up, but you're not seeing the ascending aorta and arch normally. You see, it's a very foreshortened view of the ascending aorta, and you're seeing the aortic valve end on. The ascending aorta is very much foreshortened. That means you're looking into the ascending aorta from the region of the apex, and the whole heart is foreshortened. Therefore, this LAO view is market caudal. Typically, we give about 45 degrees LAO and 45 degrees caudal, and this the neck vessels and the arch and the aorta, it's not possible to comment in this view. The only thing you can comment is the three sinuses 1, 2, and 3. You will be able to identify which coronary artery is coming out from which sinus. You are able to separate the left and the right coronary sinuses and the non-coronary sinus, and you will be able to separate them completely. Okay, this is the laid back view. We commonly use it in tetralogy of Fallot if you are not sure about the coronary anatomy. You can use it in transposition of great arteries if you are particular about seeing the coronary anatomy and angio. The three sinuses are very well defined, 1, 2, and 3. So this would be the anterior sinus, the left posterior and the right posterior sinus in the case of transposition. And you can see that the right posterior sinus gives our right coronary artery in the transposition. Left coronary artery would come off from this sinus. And the anterior sinus is often the non-coronary in with various patterns in complex arteries. Okay. This is the non-coronary, right posterior and left posterior sinus. This is a laid back view. Okay, Kavita, do we have time or is time over? Well, I think we are running short of time. I'll just show you one more angio just for interest, echo recording for interest, and then we'll wind up. Have a look at this echo recording and tell me what you. FLL people. Oh, I don't know why you're not seeing the angio there in the screen. 1 second. Can you see it now? Can you see the image?